السلام عليكم. Good afternoon. عارف أنواع.
Thank you, Fahad, for the nice introduction. I'm so glad to, first of all, to be with you today. I congratulate you and the organizing team for the wonderful event again, as usual, and they need really to be congratulated for this and from one success to another. Second thing, I would love to wish our country, United Arab Emirates, a wonderful National Day. This is the 53rd National Day, so we are very pleased to have you on board with us today. Second, today it is really going to be something, we change our plan a little bit. We have a wonderful case and very provocative as usual. And I don't know where we will land today at the end of this case, but I am sure with your guidance and your help, support and opinion, we'll end up safe at the end of this case. So this makes the situation a little bit exciting. I hope you will share with us this excitement. On my right side, as you mentioned, Dr. Wael, and have Dr. Muhammad, and we have a wonderful team. It will be taking too much time to mention all of them, but thanks to everyone around me. And now next we'll go directly, if you don't mind, Fahad, to Dr. Muhammad for the case presentation, please.
Sure. Thank you, Dr. Arif. Good evening, ladies and gentlemen. It's my privilege to be presenting today's case. My name is Dr. Muhammad Ashraf. Next, please. Our patient today is a 64-year-old male. He is a smoker and hypertensive and pre-diabetic, but showed no relevant cardiac history before. Next, please. He was admitted to our hospital on the 23rd of November with unstable angina. His labs showed mild elevation in the hemoglobin A1C and the borderline labs of the lipid panel, but negative troponin and otherwise normal labs. Next, please. ECG showed ischemic T-wave inversion on the anterolateral leads and a sinus rhythm. Next. Echo was done and showed a mildly reduced LV systolic function with an estimated ejection fraction of 52% and a wall motion of apical hyperkinesia. Angio was done on the same day, and RCA showed a long, diffusely calcific lesion with multiple tight spots. As for the left system, next please. The LAD showed an extended multiple calcific lesions from the proximal all the way to the mid, as well as the second OM showing a proximal significant as well calcific lesion. Next, please. Centric score was done for this patient and it came out as 25. Based on that, a heart team discussion was done. And these methods of revascularization was on the table, but the patient opted for a PCI. Thank you. Back to you, Dr. Arif.
Well, Fahad, thank you and your panel. You have a good case to debate and discuss. Before I say our strategy, this is a gentleman, a little bit unusual to have negative troponin. So he was admitted with chest pain and negative troponin, but significant ECG changes with some echo finding as well as the apical part. And we have seen peripheral vessel disease, but and with heavy calcification, mainly on the right side. So one of the questions I would raise, how would each one of you, if we can just make it a bit quick, because we have a long process or procedure ahead, and which one would you start first, the right or left? That's also something. And what kind of tools would you use? Go ahead.
Okay, so I have a great panelist here with me. Probably I'll start with Jalal.
Yeah. Well, if you see this angiography, you've got a significant lesion in the proximal LAD, and because the patient presented with acute coronary syndrome, I presume this must be the culprit vessel. So I would start first with the LAD, and then if it goes without complication, finish the case with the RCA. I think that would be appropriate for the time being.
Dr. Abdullah, will you do both on the same session?
Well, I think for the LAD, I will do the LAD and the RCA in the same session, and then maybe later on for this OM to be evaluated later.
Annie?
I think if I'd always
So
start with the LED.
you agree that the LED is the culprit here?
Yeah, it's a critically tight LAD, and the ECG changes are mostly in the LAD territory, so are the wall motion abnormalities. So it has to be the priority, right? So I'd fix the LAD first, and then if he's stable, pain-free, we're within our safe contrast range, I'd continue and do the RCA. If he's unstable, you can always stage it for another day.
While?
First, thank you very much. It seems to be a very exciting case. For sure, I will go with the LED. Like technicality of using, the imaging and be ready for any modality of calcium modification.
Dr. Siraj, your strategy for this case?
I think I will go only LAD today for first session. I will not do LAD and RCA the same session. LAD is a complex, highly calcified disease, especially in the proximal LAD part. So it will take time, preparation, imaging, probably using some atherectomy, then probably stenting. So I think do the culprit LAD and then move on in another session into RCA.
Right. However, the session is about calcified lesions, so everybody looking forward for that RCA with too much calcification.
Stop here.
Yeah.
So, Fahad,
Yes, Arif.
you will be. Do you hear me? Okay, so we have anatomical challenges here. One, as you said, the number one enemy, the calcium, which is angiographically not very significant in the left system as it is in the right, but we assume this is going to be something. There is some trace of calcium in the LAD. I wasn't expecting it to be that bad, actually, in the fluoroscopy. Second, this whitish there, I was in doubt whether there is a thrombus material there. That was not very clear. Third, there is aneurysmatic changes, which is overlapping between the first diagonal and the LAD. I'm not sure where that exactly is. That is one challenge. Fourth is the two large diagonals involved, but luckily we don't see much of the affecting the ostial parts of the two diagonals. So those are the anatomical challenges. We have some mild bridging at distal LAD, and there is also a second lesion. So we have a proximal lesion, we have angiographic distal lesion, we have two lesions to take care of. Luckily, we have a proximal angiographically not a disease segment, so ostial LAD angiographically is not involved, and we have good landing zone distally based on angiography. So if you don't mind, I will go now. We did some imaging assessment. I'm sure everyone will look at the change in the CT or I.
Arif, I think I should give you two sessions. One LAD, we call it complex PCI, and RCA, we call it calcified lesion. So you have the opportunity.
Let me surprise you, because the plan was initially to go for the right, because it is really heavily calcified angiographic. As we said, Fahad, yesterday in the meeting also we discussed this. But after doing an imaging, I suggested to do an imaging and see, because the plan was initially to do off live the LAD and then move to the RCA live. That was our initial plan. When we did the imaging, I saw that this was a complex enough. There is enough calcium for you, my friend. So don't worry, you will have enough calcium. So let's go with the first OCT without any delay, please. And then I would love to hear, if you want me to comment, I'll comment. And then I heard some Dr. Hani is also there.
Yeah, Hani is here. We'll ask him to comment about the OCT.
All right, let's go from proximal to distal LAD, please. Do you see the OCT on full screen?
Yes.
Yes, we do.
have a co-registration actually. So maybe you can keep the co-registration, both angio and OCT, please. Thank you. Let's go. So we move from the left main, going down with this distal. And we come to the circumflex, and then goes to LAD. And from here, we can see that we have some relatively good landing zone, some calcium. There's a little fibrocalcific segment which approaching the proximal mid LAD to the first diagonal. And then we come closely to that part, and we can see calcium fragments right and left and islands spread it around. We can see here, this is what I say Batman sign, the more devilish shape. This is something, I think this looks like 2 nodules or multiple nodules, but mainly the one between 6 and 9 o'clock and one between 11 and 4 o'clock. You can correct me, Hani, later on if you wish to. But this is what we see. Move forward, please.
Out of this is going to meet the objective of the session.
And if you come back just a little bit, we're just going to move a bit forward. Let's go back to the lesion. Just to the lesion and move forward very slowly after the lesion, just so we can see it step by step.
Here.
So, yeah.
Sure.
So here we are. This is our bifurcation of the diagonal, right? And the co-registration is confused and it thinks that we're in the diagonal, but it's okay. We can actually see that we're very close to this ostium as well. So, you know, it is a slight concern about this diagonal. We're going to see this in 2 views. We're going to see it now, and then we're going to go back and look at our longitudinal view in a bit. And now if we just move forward very slowly.
Let's go forward, please.
Yep.
And here's the diagonal.
That's a diagonal. We thought this was the 7 o'clock diagonal coming after the calcium.
And we can see there's this nodule as well, right? You can see the nodule towards, what was it, 4 or 5 o'clock?
3 and 5, or 3, 6, exactly.
Yep. And as we then go beyond, we've got a fairly reasonable distal vessel beyond this lesion so far. Can we do one thing? Can we increase the size of the longitudinal view?
The longitudinal view.
Yeah, the longitudinal view, make it bigger.
Okay.
You can do this if you
leave it to the longitudinal view.
Yeah, if you leave the co-registration, if you take it off the co-registration and make the longitudinal view bigger. So if you go,
can I, Dr. Hani, just go one run and then we do what you want. Just have an idea what's going on. Let's move, please.
Yeah.
Okay, go back to the lesion again.
Yeah.
So because things will be maybe more clear. Okay, let's go down. Distal now. Let's move, please, forward. Yeah.
Because what?
So this is the lesion that we are concerned about, involving a large diagonal.
Yeah. What we're hoping to do is yeah, because what we're hoping to do, Dr. Harif, is to see it in the longitudinal view. It also gives us a nice lumen profile where we can see it in both. You can see it axial, which we've done, and the lumen profile gives us a nicer idea of the bifurcation as well.
Absolutely, but I just wanted to show you the lesion that we are dealing with first all together.
Yes.
And then I'll go back to that focus of interest.
Yes.
I mean, Arif, this is clearly there is a calcified lesion at a bifurcation with nodules. We see there.
We can see 1.4 thickness even.
Yes, and that's indicate the importance of imaging during complex PCI. So that's very important message that we have to deliver today. Importance of imaging during complex PCI, and that's clearly shown in this case. If you don't mind, I'll just ask the panelists what will be the strategy in this case.
It's like it's more than. I agree with Fahad. It's a true definition of complex. There is a calcium, there is aneurysmal part, and it's bifurcation. So imaging is really very important, and nothing gives you crystal clear appearance more than OCT in this lesion.
Just go.
I move where?
So we are coming toward distal part, distal LAD. We have here also a calcified island between 1 and 4. So you see it's diffusely disease throughout the vessel, proximal and medial. Can we move forward, please? We will come across the bridging part, which is also quite tight at the origin of that. Here we can see it nicely, the calcium more than 200 degree. Here it's quite tight lesion, as you see next to the septal branch, with a lumen of maximum 0.8, I think here, something. Here we go. It's a soft plug, more or less small islands, deep, but of calcium, but I don't think we need any calcium verification in this particular segment. Okay.
We have another lesion. Arif, if you allow me, I mean, we have calcified we have calcified lesion with nodules, bifurcation, and aneurysm. I will just ask the panelists what type of plaque modification that they would like to use. So Jalal, in this case, in the presence of aneurysms especially.
Based on the OCT and the spiky nodule, I think orbital atherectomy would be suitable. And if we obtain good results, we can complement it with IVL to get good results. And after that, we can wire the diagonal. My only concern was the bridge in the mid portion to the LAD. I was thinking.
Arif, do you hear us? So Jalal is going with IVL. Hisham? Can we get quick answers, guys, so that we'll have them time to...
We have to move, right.
I think we have all types of calcium, the superficial nodule and the deep calcium. You go up to 1.4, 1.5 depth, so probably at the bifurcation, it's going to take more than just shaving the surface of it. You might go quite deep, so might be combined rotatripsy.
Okay. Siraj?
Yeah. I guess because
In one word, please, your modality in this case.
I will use both. Probably IVL and rotation atherectomy, both, not the orbital.
While
So
Go ahead, listen. No, it's very deep. I don't think orbital atherectomy will kick here and will be enough. So I think rotational is a must, and probably IVL as well, both in this, especially the proximal, heavily multiple nodules.
Will you go for please?
Arif,
So,
just for the sake of the time, you can tell us your strategy and move forward, please.
our strategy basically, we will start with CSI, shaving and sanding this part of the segment, going up to after the second diagonal, because there's another arc with calcium there, but we will focus on the proximal, which is more significant. Then we might assess with imaging and see whether we have gained some kind of fracturing or modification of this calcium. If not, shockwave or IVL is standby here to go for the deep calcium to improve more. With post-dilating maybe, or pre-dilating, sorry, with a non-NC balloon or scoring balloon. That's our strategy. So I'm starting with now an 80 RPM initially, and then we may increase to 120 because the size of the vessel, as we have measured, is almost a 4. So we will start with the later on to talk about this. So I'm going my first one, if you don't mind. All right. We have our crown already in the guiding catheter.
We are
and on the Dynaglide, we are going further. Come please.
fast.
Here we can see. Can you see that, Laura? All right. So maybe we can start here.
Arif, for a while, if we remove the OCT and just focus on the fluoro, what you are doing now.
Just the fluoro, please. Thank you. Sure. Okay, do you have fluoro?
Thanks.
Do you have the fluoro, Fahad?
Yes, we do now. Good.
All right. Let's go.
While you are working, Dr. Arif, we're gonna have like a couple of questions to our panelist crew. So there is an aneurysm. The IVL energy, when you have to have a good wall contact to have the good result from IVL. Now with this aneurysm, some of the energy will be dissipating, and unfortunately with this technique, if you don't have a good wall, even if you have a small pseudo aneurysm or aneurysm, the energy will be shifted toward that soft part or the untouched part or non-contact part. What do you think, Ani?
Well, I think in this case IVL will be fine though, because the calcium is very close to a very tight lumen. So there's a very tight lumen where the calcium is. So I think
قرب الميكروفون بدل دوني.
I can, okay. So I think IVL would work very well here. I think the calcium is very close to an area where there's a tight lumen, and I think you can easily get contact with IVL if you can deliver the balloon.
So do you think IVL by itself, it will do the job here?
If I
Arif is going with orbital
Continue, Arif.
Arif,
We are discussing here.
We are discussing, so it's fine.
if you
And
deliver-
stop us whenever you want to comment.
If you can deliver the balloon, yes.
Huh?
If you can deliver the balloon, yes.
Okay.
Start with the balloon. If it crosses, then you can start with IVL. standalone and didn't cross, then you have to use other modification method.
Okay.
There's no right and wrong answer, right?
Out of your plan to go at what speed with orbital atherectomy in this?
80 RPM. We want to avoid any kind of destabilization. We want to be soft, and then we may go with higher.
I congratulate you for the choice of orbital atherectomy. It's a very good choice here. So with rota and presence of pseudoaneurysm, the wire could lax and relax, and that's part of the aneurysm, and it can, like increase the risk of complication. But I think CSI is a good modality here.
And we have some people in the audience that they have no experience with orbital atherectomy. We'll appreciate, Arif, if you tell us step by step what you are doing.
While you are working.
All right. Because patient is a bit distressed, but I see the flow is there. I did some mild contrast. Okay, let's go again, please. Yeah, go.
Dr. Fad, basically we are advancing now. We advance the orbital atherectomy to the region on glide mode. We cross the region now. And
Yes.
the difference between rota and orbital atherectomy is that we advance 1 to 3 millimeter per second, not without this picking. We engage and disengage, but not a picking movement.
One more time.
This is the difference. Okay, look at the screen.
You may realize the change of the sound that
Yeah. So what I found also helpful with CSI is you do continuous saline flushing. It will decrease the friction, and it gives you better result. So you can give him like a flush of normal saline. It will help a lot.
we'll go backwards now. And we will do now, and this is bi-directional standing, so we'll go backwards now. The hemodynamic is stable. There is no ECG changes. The patient is stable. All right, go back, please.
How long are you resting for in between the ablations?
Up to 30 seconds.
Here we went back, check it out, we'll go front to the half again.
So for those who do a lot of orbital, is there an audible feedback like you get with rota? Is there a noise that you hear? Hisham, you do a lot of these things.
Yes.
Yeah, you get used to the
Hisham does a lot of orbital, so.
the sound, especially at the
Hisham,
tightest
the mic.
Yeah, you get used to the sound change, especially at the tightest point, and you're very careful now. This is
The wire.
time when the diamond just jumped.
Yeah.
So you hear
So
something.
the trick is to go
Let's do one.
forward, one backward,
Ready?
or 3 to 1, and the longer breaks is the better in terms of getting not getting a slow flow.
Okay, Hisham. Arif, I see that you have changing now to a higher speed.
Absolutely, Fahad. We are back to 120. I've seen that we have done some job,
Okay.
and I'm trying to do some more modification with the higher speed.
So, Hisham, it comes in two speeds, the orbital atherectomy. When do you use the higher speed?
Well, you always should start with the 80 RPM
Mike.
to do the whole job, and then after that you do the
And Mike.
we always start with the 80 RPM to do the job, and the 120 is usually saved for the bigger vessel 4.0 and above, because with the 80 you can get up to 3.5 vessels coverage, and most important is to do imaging even after this 80 before you switch to the 120, to make sure that you're going to reach the whole vessel wall with the 120.
So the speed, Fahad, is just for size, right? As opposed with rota, you go faster if you can't cross with the lower one. So with this one, you just go bigger, right?
So for me, if the IVUS or OCT showed the heavily calcification, you don't need to go low speed. You just go high speed and back and forth. and you will get good result. But if you have such a aneurysmal or, you know, like not heavily calcified valve, you go 120 if you want. But bear in your mind and be ready that if there is, especially in proximal lesion, the risk of dissection and no reflow. So heavily calcified, if I decide to use rotational atherectomy, CSI, I will go very high speed, no doubt. There is no time to lose, to be honest with you.
Come, please. All right.
Arif, how's the sound of it and how's the tactile feeling?
The change.
It's very,
Yeah, the change of the frequency shows that we are doing some job there, and I need to do more actually. Okay, let's go again.
So for those who do a lot of orbital, is the no reflow risk higher or lower than rota? Is the no reflow risk higher or lower than rota with
it's
orbital?
higher with the higher speed.
Should be lower.
It's less with more breaks. You have to have, sometimes you have to go up to one minute break between the.
Thanks to come up.
So the key success with this device, you go slow.
Let's go.
You go slow, and it is forward, backward, one time, and that's it. If you did not achieve a good result with this, then you can use the shockwave with it. So this is the it's not like the rotor, you know, you go 3-4 times, you change. Say it work. If not, then you go IVL.
For people who are getting used to rotational atherectomy, they go fast or picking movement, but this is different. This is, be careful with the wire.
Wire's coming. Yeah.
Yeah. So this is really, you go very slow.
Exactly, Fahad. This you should not rush. If you want to avoid complication, be patient. Okay.
At least.
And one last thing about this device is, you know, you should use it in a stable patient. As you see, it is, you know, it needs slow movement, and there is risk of, it's a risk of, you know, no reflow. So the best device for a long, I call it fish skeleton behavior. It's like you see this LED long lesion calcified. This is the best device to go with. So you go one forward and one backward.
Okay, let's go to Arif. Are you planning to take an angio now?
Yes, I did that,
Okay.
and I'm doing an OCT now.
Okay.
Yeah. Okay.
If we think that we didn't achieve enough, we will go for IVL.
Sounds like a good strategy.
Yeah,
Actually-
it's not an uncommon strategy nowadays.
Yeah.
Yeah.
Actually, you can combine the two methods of
Yes.
modification. So using the orbital first to get easier crossing for the balloon, and then you can do the IVL after that. You get better expansion for the deep calcium, especially.
Yeah. Yeah.
It's the rotatripsy. So just a question to the audience. Who has an experience with orbital atherectomy? Can we share a raise of hands?
All right, here we go.
So only about 10% of the audience. So then it's good.
Do you have OCT image?
21%.
Let's see the
Dr. Fahad, you see the...
Yeah, we do see the OCT. Yes, we do.
Okay, purge or record? Okay, let's go, please.
I have a comment.
Yeah, go ahead.
So based on the OCT image pre-orbital, it's not very clear to me, the calcium, to be honest. I don't see a lot of calcium, but probably because of the pullback, I'm not sure. So I don't think orbital in this case it will help much. We'll see now, but I don't think it's going to do much. I would have done with a scoring balloon or a cutting balloon to start with. I don't think there's anything there that necessitates the use of orbital atherectomy.
Okay.
And the
Thank
fact
you.
that the OCT catheter went through easily, it suggests that the calcium is not that significant. You know, the OCT catheter is not very deliverable, but in this case, it went through relatively easily. So we'll see now. But I don't think it did much.
Thank you for the comment. Thank you. Okay, let's review the OCT that you have done, Arif.
Sure. Let's see what we did. Okay.
One important things about this device, actually the ostial lesion. Ostial RCA,
let's go.
it's the best device for ostial RCA for calcium modification and debulking. Ostial RCA.
So we can see this very.
So we are going now, we are seeing now some erosion has been achieved here. We can see some white thrombus and some at between 2 and 5 o'clock, some platelet aggregation. See, we can see that we have done some aerating that part. This erosion has been created by the sanding. Now we come to the part that is the part that we thought it was badly, and we can see there's some kind of
There is some debulking,
I said
right?
deep fracture. Yeah, absolutely. It's not the same like before, for sure.
Yeah, it is.
You
It is a
achieved
bigger
really good
lumen.
lumen here.
Yeah.
Let's go further, please. But I don't see a fracturing of the deep calcium.
Arif, would be nice to have the co-registration as the fluoro side by side with the OCT.
Okay, let's have the fluoro with it. All right, here we go. You are just at that same part. Sorry for this. I thought we were ready. Okay, let's move forward to the lesion, the significant. That's a nodule between 12 and 3 o'clock. We can see it, but we have gained some lumen for sure. And do not forget, this is not a circular kind of calcium. This is not a circular calcium. This is a protrusion of 2 to 3 nodules, you know. So this is really a bit tricky. You don't see this kind of calcium all the time. It's a bit challenging. Okay, let's go further.
You can do
Further, please.
you can do an OCT of the pre and the post together with the software.
All right, we will do that.
Mohammed Ataibi,
Maybe so.
Mohammed Ataibi, you have a comment? Yeah.
Yeah, nice work, but just for the sake of argument, I think, yeah, it's nice demonstration of orbital, but I don't think it will
IBL
do
3.5.
anything. The tightest stenosis is the same. And I have a concern about the distal embolization if you increase the speed. So, Dr. Arif, what is your solution, or what is your mixture, or what's your flushing component?
Well, usually we don't go. In the past, we used to do a lot of, verapamil and nicardipine or whatever. But nowadays, nitro is enough for me. I never needed more with some agrasat and coronary. That is more than enough. I don't think we need more complex cocktails anymore. And besides that, we said before, if you go soft and give time and wash out, and you have already the glide solution. So that one, I never faced much of this noriflow, frankly said. But nitro is the treatment of choice. Okay, so we are going now with IVL. I'm taking the 3.5.
I think also Dr. Arif is the most important, as you said, giving is a rest time. If you are worried from noriflow, you increase your rest time.
Maybe we can exchange the wire. Can we exchange the wire, please? Can I have microcatheter?
Hani, what's the most striking findings that you have seen in this OCT, the follow-up OCT after orbital atherectomy?
I think there might be some debulking, but although I think it's actually quite humble. If we go very slowly, there might be a small dissection that doesn't appear to be very flow limiting. I would actually think IVL is very useful, but what I probably do is size my balloon on OCT, and it's fairly simple to do right now. You can easily look at your proximal and distal reference and choose a 1-to-1 because you don't want to undersize your IVL balloon in this scenario. You'd get a much better result if you're able to size it. Even if you're slightly more than 1-to-1, it's going to be okay.
I need a balloon, please, a 2.5 balloon for tracking.
Yeah. Honestly, Arif, I think NC balloon will do the work here.
I would IVL.
Optimize it, I will do more cracking and more preparation. I don't want to have
Yeah, you don't
problem
have
later with the stent.
you don't have the 360 calcium or 260.
But I think also from what Ziad Ali showed us earlier, sometimes it's not just the 360 calcium that prevents your stent expansion. I think there's some area there with very thick calcium, and you do want to reduce the thickness to improve your overall expansion. So I would agree with IVL in this scenario.
Really? I mean, if you drop
Out
the
of
financial
what size of IVL you have used? 3.5?
I'm taking a 3.5, absolutely, because I measured this one, and 3.5 should be fine.
Should be okay with the diameter of the artery.
Yeah.
Can you see the floor as you're crossing with the balloon?
And always with IVL, you should go 1-to-1.
I'm trying to exchange my wire, the Viper wire, with the workhorse wire.
Yeah. So Arif,
Taking a tracking balloon.
yeah. So let me ask a question for the audience here. There is no 260 or 300 or 360 calcium. Would you use IVL or you just go with the NC balloon? The people who want to go with NC balloon 1-to-1, raise the hand. Shockwave, don't raise the hand.
So you can see from this. So if I can just stop you guys for 1 second.
Just out of, I would like to tell you that most of the audience will go with NC balloons, and a minority will go with IVL.
Well, but I agree with your IVL, and this view right here in front of you, the OCT tells you why it's IVL. It's not low calcium. See this orange area? This has more than 180 degrees of calcium in that area. Everything in orange, automatically, there's more than 180 degrees. So this is circumferential calcium, and this would benefit.
But he used the CSI, Hani.
Even then, you've barely debulked it, barely. It still needs work.
I like that difference of opinions, so it's good.
Yeah.
It's very healthy. So that means we have different strategies.
What was the thickness of this calcium, Hani?
0.73.
It's reached 1.6.
Yeah, so that's the answer for the shockwave.
Yeah, but
It was 1.5 at the
It's
proximal segment.
it's very deep calcium, so this is really indicated for IVL.
But you see, this is where the AI helps you. It's done the job for you. 245 degrees of calcium with a maximum thickness.
But you have to
1.27.
fracture, my friend.
There's no fracture.
The one at 13, at 1 o'clock.
A 3.5 non-compliant balloon.
I don't see a fracture.
It was 280 before in the pre-OCT.
But I don't see a fracture.
There's a question, there was from Kuwait.
Let's go back to Arif. Arif, what are you doing now, Arif?
This is the IVL balloon crossing just now easily. A 3.5.
Okay. Did you have difficulty crossing it initially?
No.
No.
You can save that one. Please save that one. Save that floor, please. All right. Test, please. So I will start here. Can I start here, please? Because we had a 180 here calc with what, which was not also been modified. Okay. We have this one. Okay. Go ahead, please. 4.
Yeah.
Ready? 4. Yes. Yeah. Can we start? Okay. Yeah?
Yeah. All right.
Okay. We are starting delivering the shots. We have a 120
up.
waves.
Is the balloon shaped?
More contrast.
Yeah,
Arif, you are doing the distal legion, huh?
yeah.
You are starting with the distal legion?
Again, please. Yes, sir.
the co-registration showed that there's calcium distal to the lesion that we saw initially, which is also interesting. Shows you how poor the angiogram is at locating calcium.
Add some more contrast, please, because I can't see with
Be careful, maybe the balloon is slipped distally. Just do an injection.
No, I have the rip as a landmark potential, and I think I am good. It's fine, Doctor. Perfect. Rupture. Oh yeah. Okay. Yeah. See that one? That's the calcium. Okay. Look, it's rupture. Okay. Can I have another balloon, please? Yeah. Let's see. That's a really impressive rupture. I mean, that is something I didn't expect in this lesion at least. Maybe it's approximate, but in this one.
You did rupture at 4 atmospheres?
So the next one also will be ruptured, Arif. That's why give it an NC
We'll go
value. No,
proximal.
serious. That's how we deal with it. If the
I'll
first
take
one
one more,
ruptured,
please, for the approximation. Well, you know, welcome to the real world as usual. It never happened so far with me rupturing with the 4 atmosphere. This is really unique. I don't know. Maybe you had maybe before. How was the experience of our colleagues?
Abdullah, if you have a rupture IV balloons, what's your strategy?
I think
do you go with another balloon? Do you use NC balloon first?
For the IVL, I think one of the issues you need to prepare it very well, de-air it very well before you put it inside. That's one issue. If you have it ruptured in the beginning, then I will use NC balloon, like 3.0 in this case, and try to go higher pressure on that and see.
Okay, good.
So smart and then it's planning.
Yes, Suhail.
yeah, I would look at the balloon when he would go out. If the rupture is circumferential, like it's a calcium reduced pocket, then it will happen again. If it is a longitudinal, then it is truly calcified, no room for the balloon, and it's considered as a high pressure, and it's gonna be ruptured longitudinally.
Let me say, I mean, the distal one was not that nodular calcification. That was a diffusely longitudinal calcium. I needed just to do it. This could have been done also with the NC balloon, actually.
Yeah.
But I thought we'll prepare it. Since we have a balloon with 120 waves, we can make use of it.
It will be, it will be interesting if you should look at the balloon. Show us where is the rupture.
What is the balloon doing?
It's exactly at the rib. If you can see the shadow of the rib, you can see it on the floor actually after the second angle. I don't know if you can appreciate. You should have a larger screen than I have. There is a rib exactly at the width of that rib.
No, the rupture in the balloon itself, the body of the balloon.
Here it is.
It's a good educational session. Arif, you are doing extremely good, and we are really enjoying your skills and the amazing case you are showing us.
Let's have that. I mean, let's do it in a minute. Just let me do one more try with the shockwave, because the time is running out of us. And then if we have time, I'll show you the balloon maybe in play.
Arif, don't worry about the time. We are learning a lot from this case.
We'll ask Musa Akbar to extend the session.
You're extending my misery, right?
Yeah, because Musa Akbar took about 15 minutes from our session.
Yeah, that's true. شايفينك احنا دكتور موسى شايفينك.
مو قاصدني الدكتور موسى is doing it with intention, I know.
دكتور عارف don't worry أنا قاعد له هنا ترى.
عليك فيه وعليك فيه.
I think we are really surprised that this distal lesion is giving trouble. We expected that the one at the aneurysmal,
The OCTs showed the spikes of the calcium at the point of maximum lesion, but down there didn't seem to be so much calcium.
Yeah.
So
let's do it here, thanks.
Forward.
It's another IVL 3.5.
Yes.
Okay,
now we can
good.
see the balloon more. Yeah, let's go.
Dr. Fahad.
It's inflating nicely because it's a longitudinal one. I didn't expect it to be really. It's problem with the balloon itself, probably.
Can you do cine, عارف cine? We want to see if there is a waste or something. Man,
Nice. It's inflated. So I think I'll go to the same point that Abdullah mentioned earlier.
Yeah.
Preparing the balloon is very important in IVL and deaerate it as well. That's very important. Arif, I have good.
This is the IVL balloon.
Arif, I have a good news for you. I have good news for you.
Yeah.
We are giving you extra 10 minutes
هذا with the place of Dr. Musa.
because of the National Day.
Go, please.
Just a quick comment. You see, the balloon is fully open. There is no single waste. So the NC balloon was. So that's a nice NC balloon, the IVL.
We'll do one more.
Dr. Fahad, if you allow.
Just give it a little.
I think the first balloon, as Abdullah said, was not prepared well because it didn't inflate to start with to say it's ruptured. A second point, they can test it outside, and I'm sure they will confirm that it's not ruptured. It's a preparation issue. The second point, which proved that probably it was not needed IVL, is the fact that this is NC balloon IVL, and you inflate it, and it's widely open. So I think that's a nice demonstration, but it proves that those who voted for NC probably were not wrong.
Yeah. So that's the beauty of OCT. It showed us clearly that the calcium is fractured. Yeah.
Now you are at the proximal lesion, Arif.
6.
So how many cycles have you done in the distal lesion?
2 each, and then now I'm going to third one here in the proximal. I'll do more of the proximal.
Okay.
Just
I mean,
remember,
there's no harm. The more you do, the better it is. I mean, if you have no ECG changes, patients tolerating well, do as much as you can.
and just remember, concentric calcium responds very quickly to IVL. You don't need 50 pulses.
Yes.
Ziad was saying 4 or 5 pulses, you can pretty much crack it.
Can you comment on the pacing? Because when you inflate the IVL, there is a pacing. So I think this is a very quite common phenomena without sequence.
Save that one, please. Save that one, please, and show it. So the balloon is well expanded here.
That's interesting.
We go to 6 and down 1.
I think this is what we
No, yeah, we do.
yeah, you want it.
It is a noise become better.
Yeah, every time.
Again, please.
Like to see balloon hands.
I think everyone wants to see an OCT, or do you want us to go with NC balloon and place the stent? It's up to you.
I will go OCT. NC balloon, then give it. Do the OCT after the stent, in fact.
No, I think NC balloon, then OCT. Definitely OCT before the stent.
It's very important post IVL to go with NC balloon.
Let's do one more.
That's important. I think that's the practice of everyone. La?
Yeah, that's true.
Yeah.
No shortcuts, please.
Okay, so we'll go NC balloon, please. The 3-5 long NC balloon, please.
For
25.
educational purposes, it would be nice to see what the IVL has achieved before the NC. Because we were voting between NC and IVL.
Yeah.
So if we just went with NC, would have been enough, right? Maybe,
Yeah, but-
we don't know. Probably.
Yeah.
But let's see what the IVL did with the OCT. It's just for education.
Wallah,
You
Doctor,
will
it's
see a lot
clear.
of fractures. You will see a lot of fractures, but I offered you. It's up to you. The time is yours.
I think NC balloon first. I mean, IVL isn't there to fracture. It's there to create micro fractures, which you then expand with your NC.
You can
So I think NC then OCT.
Beautiful.
So, NC balloon, please. The 3-5 NC balloon, please.
Out of stick to your strategy, go with NC and then stent, and final with the OCT.
Wallah, NC is very
Scoring.
Here
before you stand.
NC is enough now.
So NC is enough,
Because
Dr.
I think we have done good preparation.
It's a good
yes.
We don't need NC balloon instant.
خلاص حط NC بالون وما حط NC بالون لا احنا نستفاد.
No, I'm doing the NC balloon now.
NC
Amazing.
Yep.
It's a state of art work, Dr. Arif, mashallah.
Please, Habibi. Thank you very much for your support and your very, very extremely valuable contribution.
You have the bliss of two while, one near you, one here in the
Thank you, Dr.
That's interesting.
That increase the success.
Okay, let's go at 2, 4, 6,
10 minutes.
10. By the way, 10 minutes is my time, yeah? I have
Yeah, go ahead. دكتور عارف,
Yeah.
go ahead حبيبي, go ahead. احنا موسى اكبر ما زال يبتسم.
انا ابتسم بعد وقتي ما خلص ال 10 minutes بعد ما شد. اوكي 2 4
ترى بدينا.
Okay, let me have 33 3 5 7.
Okay, clear.
Down please. Or 28, maybe 28. Yeah.
عارف, I think next
So,
you go with the stent. You go with the stent, please.
I'll do an OCT.
Yep.
I'll do an OCT.
عارف, probably you will not have time for the OCT now and stenting. Go with the stent.
Up to you. Up to you. 3 28, 3 5 28, please.
3 5.
But why you are saying I don't have time? Just now you said I have 25 minutes. Why you are changing Fahad, your statement every minute?
لا هذا موسى أكبر يا أخي.
While pressing is not working.
Because Wael is busy with his phone, so
والله دكتور موسى اكبر والله بدانا متاخرين صراحه. And this is the greatest session.
45 minutes is still. And we are
يلا
on time. Don't worry.
لا don't worry, go with the
it's
stent.
okay. Go, Arif, you go with the stent and then OCT.
And then bye-bye.
ورينا
And then you have a good rest.
Let's go. Let's go to PA codon, please.
what kind of a stent is this?
3528.
Sky point 3528 for the proximal. I'll take another one for the distal.
Yeah,
like a Zion stand.
Test, please.
That's a Zion's.
All right, here is good. Let's have PA cranial in here. So save this one. Proximal is good. It's so 2 millimeter from ostium in the proximal area. And here, let's take a shot. Right, perfect. Okay, let's go, please. 2 4 6.
Then he can understand.
Okay. All right, very nicely.
Very nice. Nicely expanding.
Man,
Opens very well.
That's it. Down.
يعني I would go longer stent, but that's fine.
He is planning another stent.
Because distal, it's a 275. I don't want to exaggerate with the 35 in the walking part. I'll take a shorter one.
Yeah,
Little 35.
you have a plenty of time, 6 minutes.
They are making deducting my time or what is going on?
No, well,
They are coming a minute less and a minute less.
yeah. Do you think there is a bridge? The bridge, don't reach that bridge, maybe.
Yeah, he's careful about it.
I will take a short one.
Yeah.
Let us have.
Maybe another view to see that.
12 is good.
Can I have? No, 12 is OCT. Everyone wants to measure by OCT. No, we will go with a stent of 18 maybe.
Yeah, 18 is good, yeah.
27580 will be good choice, Arif.
18. Yeah, thank you.
All this, yes.
And then we'll take a 3-5 and 25 for post dilate. You see the diagonals are good.
Yeah.
Yeah.
Surface. I mean, I didn't expect much, but I hope we are gonna stick to this because we did this modification and they were not that sick or diseased osteums, but let's hope it remain the same. And even the aneurysm has become less. I see it here. I think that was post-stenotic dilatation somehow, which may shrink by time. So that is also something to look at. Okay, but I tell you, this was really a tricky situation. So many of us would have gone direct NC balloon, and in retrospect, you could say that. But I tell you, in 20% of the cases, you will end up in a problem, in trouble, and you have to do some more modification and force NP balloon, or you know, that is something I don't like to go through it anymore. Since I have the tool for making my life easy, I'll make it easy. I have enough difficult tasks.
Just be careful with the wire.
Yeah, no worries. Okay, here we go. Can I have areocranial, please? Areocranial, please. And then give me a stem-boost or
Slice. Step.
stem-boost slide, please. Will be good. For sure. Okay, here we go.
I'm present.
Show me.
Oh, I let it be case.
Stem-boost, please. I think we are good.
Yeah, but make sure
Just make sure you are not in the bridge, huh?
Yeah, well, the origin of the proximal part's fine, but I shouldn't be deep in that one.
Yeah.
Otherwise, because the lesion is really okay. I don't know. It takes time to stimulate. Okay.
I will pull you, good news.
Why not?
If you pull back, Arif,
Arif, pull back.
1 second, sir. All right. I am just going back a little bit, and then I'll do an angio to see where I am. Here, there's a good overlap.
Yeah.
Now, okay. Let's do an angio, short angio. Yeah, we are deep a bit. Let's go back a little bit.
Yeah.
But not much. Here. Okay, let's go. 2, 4, 6, please. Good. 10, 12, 14. So 275, right? Okay. Down, please. 16, 18, 20. Now I need a 3-5 not compliant, please. Down, please.
a bit minor here. Okay, Arif, you can do an OCT now.
I think he wants to oppose it because the distal stent is
Come on, let me.
going to be malopposed. Let him oppose it.
He did it.
He needs to oppose the distal stent. So he's going to take a 3-5.
Nice.
Very nice to oppose the distal stent. And then, are you going to do a pot at the end, Arif, for the proximal LAD?
Yeah, absolutely. Yeah, just give me a minute. I have time, really, guys. Why you have time? I see that it's in the front of me. It is still I can use the 45 minutes.
No, Dr. Musa said we have half an hour. It's okay.
Arif, you don't see how many people on my head telling me the time is over.
Why? But this is my time. No, the time is not over. For sure, not ever.
Well,
I have it in front of me.
I being Arif,
Arif, and geographically we have an excellent results, so we'll have time for run of OCT, please.
Okay, all right. That's your choice, my friend. It's your choice. Whenever
Yalla, okay.
It's your decision. 6, 8, 10, 12. We are at the end of the procedure.
So what's this NC balloon?
3, 5, 3, 5,
3-5,
14,
okay.
16 down.
You are dilating the overlap?
yeah.
Yes, sir.
Okay, sure.
And then we go again here. 16. I don't want to exaggerate with the pressure. There's
it's good.
fuel. I don't want to.
Oh, look at
Just 14, 16.
you can go 40-10, you're gonna have better images.
Center, please. Center, please. Can I have PA corridor, please? PA corridor, please. And I need a 4, please. Yes, please. All right, here, please. 12, 14, 16, 18. Down, please.
Can it be nice? Maybe a nice one.
Now 4 for the pot.
How high did you go, Arif, on the proximal segment?
Proximal, I went to 18. It's a 4 diameter. We measured it before. So we had the reference of 4 actually. We were thinking whether to place a 4 before that and then go with the 3-5 distal or 3. And then we decided to go with this strategy, the 3-5 with 1 stent. Crossing that, also avoiding the overlap at the level of the diagonals. That was the aim.
So you have the OCT now?
So 4 should be fine. No, I will take another minute from you. That's my right. Isn't it why?
Yes.
And Musa has decided.
It depends on Musa Akbar if he agreed.
You use your influence, yeah, Fahad, use your influence. 6, 4, 10.
This is nice demonstration how عارف Nuriani is a powerful guy.
عارف الوقت كله لك.
والله تحسدون على الوقت على دقيقة حرام عليك. جو خلصني خلص. اوكي.
والله انت واسطة يا عارف.
عشان العيد الوطني بس والله وراسك.
والله صفقة.
Okay, we'll go a little bit back. Go, please. Yeah. 2, 4, 6. Gently, please. I don't want to dissect the OCT. 12. Big. Wait. Down, please. Okay, your OCT for Fahad before he switched off the whole screen. Right. Sometimes you need dua al-walidin, you know. What is dua al-walidin?
يلا القص. ما فيش.
والله جميلة ما شاء الله.
And geographically it looks nice.
والله very nice.
I think he didn't need OCT.
خلاص, give us the final OCT.
It's on the way. It's on the way.
يلا يا وائل بسرعة الله يخليك.
Are you having lunch still? Or did you have lunch already?
Okay, until you do this, we'll ask the panelists about what their strategy for these antiplatelets for such complex PCI patients.
All right. Ready?
Jalal,
Ready?
antiplatelets, what you will do with antiplatelets regimen for
Well, I
this?
think the case was done relatively nicely, so it was well positioned. So I think a dual antiplatelet for 1 year would be enough.
No, what combination?
What combination? you will do?
Well, this was an acute coronary syndrome, so I think Tika and aspirin would be appropriate because the case was an acute.
Good.
So,
The moment of truth.
والله يا فهد still you are doubting in our sort of capability يعني حرام عليك يعني.
لا.
Angiographic looks okay, yeah, angiographic looks okay. This is only for the sake of education now. I hope everything is okay.
Apply the max now.
You can see the calcium, the eccentric nodule pressed down. You can see some staining there.
Septals.
But the diagonal septals, all branches almost preserved. And see, it's a dominant LAD, really. That's why he had hypokinesia at the apex. The flow is symmetry flow, almost distal, a little bit of some embolization, or maybe some degree of slow flow, but it is okay. We give some nitrate, please. But it is a beautiful result, all in all. We'll see the OCT. And
Let's see the OCT, Arif.
that's it. And then we will decide.
Yes.
All right.
Great.
So we'll see the H dissections, we will see the expansion, and we will see the malappositions in case any there. Left main coming. Right, go please. See the ostium. We left up 1-2 millimeter. I hope there is nothing. Fantastic. Oh, I don't see any edge dissection at the proximal edge.
Very nice.
Expansion.
Nice expansion.
Good expansion. No malapposition. No dissection.
That's good.
We're going to see the bifurcation shortly as well.
Let's see. Let's see.
Stuff.
This you cannot do. This is kind of invagination, that you cannot cover. We've done with the 80 pressure.
There's the
This is
bifurcation
the
coming up.
aneurysm. You cannot do this.
This is the aneurysm.
No, this is fine. Yeah. This is, well,
The aneurysm. Yes.
but this needs to be hit again.
Aneurysm that you are crossing. This you cannot, even if you do more here, you are just rescuing a rupture of this part. I don't advise you to play with this. On one side it's well opposed, on the other side it's aneurysm. That will be like that.
Yeah, so,
Call him later on. He will use dual antiplatelet therapy. Let's go distal, please.
yeah. So what,
We are coming to the overlap now. Yeah.
What I used, I found useful in such malposition with the aneurysm is you go a nominal with a non-compliant balloon, not NC balloon, sorry, the semi-compliant, just a nominal. It will be more, like toward better apposition.
Like you.
That could be a strategy we do at Sahim. We have a tiny edge dissection, but that is really superficial and not for anything to be done. For sure, nothing to be done for this kind of dissection. Less than 1 millimeter, very much in the intimately flow. So that is kind of dissection that you don't touch or doesn't require anything. So with this, I think that
Arif, you showed us an excellent demonstration of a complex calcified lesion. You showed us the importance of imaging in this case. You used orbital atherectomy, you used IVL, then confirmed with an OCT. Excellent results. Thank you very much. Thank you.
thank you everyone. Appreciate it.
Thank you, dear panelists, audience. Thank you very much for your attention.
Thank you.